Okay, welcome to the atrial fibrillation. What are the first things that we consider when we see atrial fibrillation? What do you think? The first thing that we consider, number one, first consideration, what do we look for? Number one, we look if there's any symptoms or not. Symptoms, is there any symptoms? Okay. And what are the second thing that we look for?
Whether the patient is stable or unstable.
Stable, okay. Because if not stable, what do? We shunt them, synchronized. Okay. So now, what are the third thing that we do? We do rate control. What is our target? Should be 110. Okay. And now we're gonna have two options. This could be either if there is a positive congestive heart failure, acute decompensated heart failure. How do we manage it? If there's acute decompensated heart failure,
we give digitalis.
Okay, digoxin, or what else? Amiodarone. Okay. What if there is no negative acute decompensated heart failure? What do we give?
We will give calcium channel blocker.
Channel blocker like diltiazem. Or what else?
We'll give metoprolol.
Beta blocker like metoprolol. Okay. So basically simple and easy. That's the third thing. What are the fourth consideration that we take care of?
We have to do the anticoagulation based on the CHAD-VAT score.
Excellent. Anticoagulations. Okay. So, and then even if shocked, you could anticoagulate for 1 month. Anticoagulate for 1 month if the patient is shocked. Okay, so that's the thing. So what are the CHAD-VASC criteria of anticoagulation? What are the CHAD-VASC? This is basically the CHAD-VASC. CHF for C, H for hypertension, A for age, okay, more than 65/75, we give point for each one. CHAD, D, diabetes. S for what?
Previous history of
stroke, that's we give 2. CHAD, VASC, what is VASC for? For coronary artery disease. VASC all one thing, so let's make it easier. Coronary artery disease or peripheral vascular disease. Thus we give it 1, 2. Okay, so each one is going to be 1. Okay, except the stroke is going to be 2. So this is CHAD-VASC. If the CHAD-VASC, CHAD-2-VASC, if it's more than 2, if it's 0
to 1, we don't do anything.
None, yeah. 0 to 1, let's do it like this. 0 to 1, yeah. Because if 1, you can either do nothing or age. But let's make it simplicity. 0 to 1, nothing. If it's 2 plus, then anticoagulate. Okay? Now, what are the options to anticoagulate? What do we have? We have warfarin. And we have what?
We have factor 10A inhibitors.
And we have the novel oral anticoagulant, which means like dabigatran, apixaban, and rivaroxaban. What is the difference between these? The difference that so both of them we don't need to bridge. Okay, but the difference is that with the warfarin we need to do INR goal of 2 to 3, and we gotta check the labs, and we gotta monitor diet, right? But it's reversible. Okay. What about you have to bridge? What about the novel oral anticoagulant?
We don't have to monitor with INR.
Okay. Yeah. So while the rivaroxaban What is it? We don't need no bridge. Basically, it has all the benefits that warfarin doesn't. No bridge, no goal, no labs, no diet. But the only side effects is that no reversal. You can reverse it. Okay. Well, this one you have to bridge it with warfarin. You have to monitor the INR. You have to do labs, like every day for 3 days, and then once every month. Okay, for the labs, for the INR. Then you gotta watch your diet, reversible. Okay, all these good stuff. Now, so basically the summary of atrial fibrillation, it's pretty simple, straightforward. We gotta start like either diltiazem or metoprolol, and we do anticoagulation. Simple, if I want to make it simple. Anticoagulation, not in everyone, depending on the CHAD Vasque. CHF, hypertension, age, diabetes, stroke, or Vasque coronary artery disease. If they have 2+, then we do the anticoagulation. Either could be warfarin, could be rivaroxaban. Rivaroxaban, I prefer it, but it's more expensive. And we got to look at the stability. If it's unstable, we shock and we anticoagulant for 1 month. And that's basically the summary of atrial fibrillation. Thank you so much for listening.